Today, we're diving into a fascinating study looking at how surgical techniques impact outcomes when fixing a common issue in our canine companions, the rupture of the cranial cruciate ligament.
Absolutely. The cranial cruciate ligament is a primary stabilizer of the stifle joint, which is essentially the dog's knee. It prevents the tibia, the shin bone, from shifting forward excessively relative to the femur, or thigh bone, and also helps limit internal rotation and hyperextension. When this ligament ruptures, it's one of the most frequent orthopedic problems dogs face.
And this rupture leads to instability in the stifle joint. This instability is a significant factor in the progression of osteoarthritis, a degenerative joint disease, and can also lead to injuries of the menisci, which are shock absorbers within the joint. A core part of this instability is what's called cranial tibial thrust. This is the forward force on the tibia that happens when the dog is bearing weight, due to compressive and muscular forces acting on a backward-sloping surface on the top of the tibia, known as the tibial plateau. This forward force was the basis for developing procedures that change the angle of the tibial plateau.
One such procedure is the cranial closing wedge ostectomy, first described back in 1984. The idea is to surgically remove a wedge of bone from the tibia and then close the gap. By reducing the angle of the tibial plateau, this procedure reduces or even eliminates that cranial tibial thrust, providing dynamic stability to the joint during the weight-bearing phase of gait.
However, the traditional cranial closing wedge ostectomy technique has some recognized drawbacks. These include its inherent geometric imprecision and the effect of shortening the tibia, which can potentially lead to the stifle joint straightening too much. Researchers have also found that in this procedure, because the bone cut is performed away from the joint center, the upper part of the tibia pivots cranially, displacing the intercondylar eminence and causing a shift in the alignment of the long axis of the tibia. This tibial long axis shift affects the angle of the tibial plateau after surgery.
Residual instability in the joint from inaccurate correction is a disadvantage of cranial closing wedge ostectomy. This has led to the development of several alterations to the original technique. Modified cranial closing wedge ostectomy techniques were more recently described adaptations that included surgical plans designed to more accurately and repeatedly level the tibial plateau to the desired 4 to 6 degree interval, while minimizing tibial long axis shift and its impact on tibial length.
Instead of the traditional right-angle wedge bone cut, perpendicular to the tibial long axis, as designed by Slocum and Devine, one modified technique described in 2013 used a juxtaarticular isosceles wedge bone cut, 5 to 10 millimeters distal to the tibial tuberosity, leaving an intact small caudomedial cortex or hinge. Another alternative proposed in 2017 was also based on a juxtaarticular right-angle wedge cut, 3 millimeters distal to the tibial tuberosity, with the distal bone cut intersecting the proximal bone cut at approximately 66% of the distal bone cut's cranial caudal length. Lastly, a technique described in 2018 also used a juxtaarticular right-angle wedge cut, 2 to 3 millimeters distal to the tibial tuberosity, but altered the location of the wedge's apex, or point, within the proximal bone cut line to achieve both cranial and caudal cortical alignment upon reduction. While these clinical studies varied, they all reported mean postoperative tibial plateau angles close to or within the ideal interval of 4 to 6 degrees.
However, contrary to the traditional technique, no studies had yet calculated the ideal wedge angle needed in these modified techniques to achieve the ideal 4 to 6 degree range for the tibial plateau angle.
The purpose of this study, therefore, was to investigate how the tibial long axis shift affects the final tibial plateau angle in 4 different cranial closing wedge ostectomy techniques, the original Slocum and Devine technique, and the modified techniques by Oxley et al., Frederick and Cross, and Christ et al. The researchers hypothesized that in the study techniques and within the range of wedge angles investigated, the tibial plateau angle varies in a linear fashion as a function of the ostectomy wedge angle, independent of the specific shape of the upper tibia. If this hypothesis was true, a corrective factor could be applied to the preoperative tibial plateau angle to calculate the wedge angle required to obtain a postoperative tibial plateau angle of 5 degrees.
The study utilized computed tomography scans of 15 client-owned dogs. These dogs were selected to provide a wide range of body weights and varying tibial conformations. The population included 12 different breeds, with a median weight of 12.6 kilograms and a median age of 2.2 years. The reasons for the scans were diverse, including medial patella luxation and cranial cruciate ligament disease. The median tibial plateau angle before any simulated surgery was 23.5 degrees.
Using computer graphics software, 3D models were created from the scans. Each model underwent a simulated cranial closing wedge ostectomy using each of the 4 techniques, with cranial cortical alignment. Wedge angles from 10 to 70 degrees were tested in 10-degree increments. In total, 433 3D models were analyzed.
The results showed that within the tested range of angle corrections, the tibial plateau angle varied in a linear fashion with increasing wedge angles. This linear relationship was observed regardless of the proximal tibial conformation. Statistical analysis indicated a difference between techniques in their relationship between wedge angle and tibial plateau angle correction.
Within the tested range, the final tibial long axis shift also varied in a linear fashion with increasing wedge angles. All techniques induced a tibial long axis shift, and its magnitude increased with higher wedge angles. This shift was more pronounced in the modified techniques as described by Frederick and Cross and Christ et al. After cranial cortical alignment. The statistical model for the final tibial long axis shift also showed a different response to the wedge angle among the techniques.
The study found that tibia shortening and wedge base size were more pronounced in the traditional Slocum and Devine technique and the Oxley et al. Technique when compared to the other more recent modified techniques. This difference became more apparent with larger wedge angles. Craniocaudal translation of the proximal segment, needed to achieve cranial-cortical alignment, was also more pronounced in the traditional technique beyond a 40-degree wedge angle compared to the modified techniques.
Regression analysis of wedge angle on the change in tibial plateau angle allowed for the generation of individual corrective equations for each technique. These equations allow calculation of the wedge angle needed to achieve a desired tibial plateau angle correction, such as reducing the angle to 5 degrees.
Using these corrective equations, all predicted final tibial plateau angles for the tibias in the study were within the target range of 4 to 6 degrees. However, statistical analysis identified differences between the mean predicted final tibial plateau angles of the techniques. Specifically, the Christ et al. Technique resulted in a lower mean final predicted tibial plateau angle than the Slocum and Devine and Frederick and Cross techniques. Predicted tibial long axis shift and percentage change in mechanical tibial length also varied significantly between techniques.
The mean predicted tibial long axis shift was lower for the Slocum and Devine and Oxley et al. Techniques compared to the other two modified techniques. For mechanical tibial length percentage change, only the Slocum and Devine and Oxley et al. Techniques were not significantly different from each other.
In the discussion, the authors state that this in silico study was designed to quantify the impact of tibial long axis shift on the postoperative tibial plateau angle and improve surgical planning accuracy. They observed that all techniques induced a tibial long axis shift that significantly affected the final tibial plateau angle. The strong linear relationships observed between wedge angle and tibial plateau angle correction and between wedge angle and tibial long axis shift support their hypothesis.
This suggests that the shape of the upper tibia did not significantly affect the tibial plateau angle correction in this dataset. The generated equations represent a dynamic adjustment for the tibial long axis shift that occurs with increasing wedge angles and may be applicable across different tibial conformations. The use of these equations in planning may improve accuracy compared to previously reported static calculations.
The tibial long axis shift was similar across techniques up to 40 degrees, but became more pronounced in the modified techniques beyond this threshold. This appears to be because the traditional technique involved greater backward translation of the proximal segment to achieve cranial cortical alignment, which reduced the tibial long axis shift compared to the shift seen after just axial rotation. The modified techniques, however, used minimal or no caudal translation. Achieving accurate cranial cortical alignment was thus particularly important in the traditional technique for reaching the target tibial plateau angle in this simulation.
Amongst the modified techniques, the Frederick and Cross technique consistently showed greater tibial long axis shift. Although the Frederick and Cross and Christ et al. Techniques had a pivot point located more craniodistally, leading to greater axial rotations before alignment compared to the Oxley technique, the Frederick and Cross technique had smaller wedge base sizes. This resulted in less disparity between the front and backbone surfaces and required less caudal translation of the proximal segment for alignment.
Tibial shortening is a known consequence of cranial closing wedge ostectomy. This study confirmed that the newer wedge designs were more effective at limiting tibial shortening compared to the original technique. This difference was more pronounced past 40-degree wedges, with the traditional technique showing up to a 40.9% reduction in mechanical tibial length, compared to maximum reductions between 7.5% and 12% for the modified techniques. The traditional technique's right-angle wedge shape and the apex located at the caudal tibial cortex resulted in the distal bone cut being further down, creating larger wedges for the same rotation and thus more shortening.
The progressive increase in tibial long axis shift with higher angled wedges may explain the range of wedge angles recommended and the average postoperative tibial plateau angles reported in previous studies. The study found that for each technique, there was a specific tibial plateau angle, where the wedge angle required to achieve a 5-degree postoperative angle transition from being less than the original tibial plateau angle to being greater than it. Since most reported preoperative angles are below these values, previous findings of effective wedge angles being slightly lower or equal to the preoperative angle make sense. Calculating the wedge angle simply as the original angle minus the target angle, without accounting for tibial long axis shift, could also contribute to variability in reported postoperative angles.
The surgical planning was standardized across techniques in this simulation to allow for direct comparison. The juxtaarticular proximal ostectomy location was chosen due to its growing popularity among surgeons and its association with less tibial long axis shift. Major adaptations were only needed for the traditional technique simulation, as it was originally described with the ostectomy further distal and with caudal cortical alignment.
The study investigated angles up to 70 degrees, though the patient population mainly had tibial plateau angles up to 38.7 degrees. While efforts were made to include variability, the possibility of selection bias exists, as only one dog had an extreme angle. Despite this, the predicted final tibial plateau angles for the studied tibias were within the ideal range, suggesting the equations are reliable within the studied angle range, though their reliability for extreme angles cannot be inferred.
The simulated nature of the study was both an advantage and a limitation. It allowed for direct comparison and eliminated real-world variables like individual anatomy and surgeon effect. It also removed variability from factors like joint disease or X-ray positioning. Once the tibias were oriented correctly, manipulation of the upper segment in the simulation didn't change the original tibial position, removing another potential source of variability.
However, the simulation did not account for real-world technical variations like the surgeon's skill, the size and location of the saw cut, or the width of the saw cut, which could affect the actual outcome. Marker placement and measurements were done by a single observer, though high reproducibility is expected based on previous studies.
In conclusion, all cranial closing wedge ostectomy techniques investigated lead to various degrees of tibial long axis shift, and this shift significantly affected the final tibial plateau angle achieved.
By accounting for the tibial long axis shift, the equations generated by this research have the potential to improve the accuracy of surgical planning for these procedures.
The authors suggest that future studies should prospectively evaluate whether using these equations in real surgical cases helps surgeons more consistently achieve the planned target tibial plateau angle of 4 to 6 degrees.
Thank you for listening to the Veterinary Research Channel. A link for the reference paper is in the video description. Remember to test your knowledge by answering the questions in the description, and as always, keep those minds inspired, hearts light, and tails wagging.